Welcome everybody to session one. Really great to see so many of you join us today, following the initial intro session we had a few weeks ago. Today's session is on protocolizing decisions and streamlining. We've got some great speakers sharing some case studies with us today. Packed agenda, so we've got a lot to get through. After each speaker, we'll have a bit of time for Q&A for that particular case study, but then we'll come back towards the end of the session to collect people's thoughts and pick up any questions that people might have, but at the same time pop them in the chat, and we'll keep an eye on that as well. So see from the agenda today, we've got Nikki Lawrence from Bath, Elizabeth Bright from Cornwall, Praveen Pillai from Shrewsbury and Telford, and then Ellen Quinney from the North East London Cancer Alliance. So we've got a lot of information to share with you today. The slides will be available to you afterwards, and obviously the recording will be available as well, so you can listen back and pick up on any bits of information you may not have picked up on straight away. I think it's always helpful at times just to go back and pick up on the recording again. Particularly if there's things you want to share with some of your colleagues, as well as representatives who are here today for your organisations. As usual, a few ground rules, a few expectations around the session. Cameras on where possible, just so the speakers know that they're speaking to people. I often find myself, when I'm speaking to a blank screen of blanks, I do wonder if people are actually there listening. So it's always great to have people on the screen as well. So respectfully for our speakers, they actually know people are there. Everybody on mute apart from the speakers, please, unless you're speaking. That's helpful in terms of any sort of background noise, to avoid any interruptions. And when we do get to those questions, please do ask. If there's something you want to pick up on, or you have a query from any of the speakers from today, please do pop your hands up and participate, because it's really important that we use these sessions meaningfully. We will keep to time, so we will finish on time, and that involves, a degree of the kind of active listening, so we understand what each other's points are, and understanding the contributions from others. But more importantly, keeping that open mind as you take some of these case studies back to your own organisations. These are case studies from the individual organisations, and I'm always very keen to stress about how we can borrow and take some of the learning, but it won't be exactly transferable. But it's how you keep that open-minded to a sense of this is something we can learn from and adapt to our own organisations. There won't be a copy and paste element to any of this. So keep that in mind about how you translate this back into your own organisations, and in that degree of following up those commitments that you make from today and other sessions, that you will go back and take those to your organisations and start to learn from these sessions. It's really important that we treat these as learning opportunities, and then how you then feedback and learn the application for your own work. So we've got, as I say, we've got a lot to get through today. So we're going to crack on with the speakers, and I can see that Nikki is ready and waiting to kick off and tell the case study from Bath. So going to hand over to you, Nikki, and the floor is yours.
Thank you very much, and good morning, everyone. So I'd just like to talk you through our unit in Bath. I'm one of the breast surgeons, and we took on sort of MDT transformation quite a long time ago now, maybe about 3 or 4 years ago, when the introduction of streamlining came in. We're a sort of district general hospital. We see about between 400 and 500 cancers a year, depending on where the screening vans are. We discuss about 70 patients on average in our MDT a week, and we take between an hour and a half to 2 hours to do that. And we took that initial idea of streamlining slightly sideways. There was some resistance to taking patients out and forming a sort of stratified different pathway, partly because the time to do that seemed a fair amount. And in addition, there was a reluctance to leave people out in case there was something specific that might be missed. So there was a push really to keep everybody in, but to concentrate more on pre-planning and pre-populating of our outcomes. So if I just take you through what we do on a weekly basis. So next slide, please. So we produce an MDT list populated on Teams. So it's really easy access for everybody, and there are sections I'll show you as we go through. And then the MDT prep is done by one consultant surgeon every week. And that's a 5-hour period of time where every single patient is looked at by a consultant surgeon. And we chose the most senior person because they really should know most of the pathways and most of the questions and the information that would be required to be able to discuss those patients. So that, time in the MDT where someone goes, oh, what's the ER, or did they have chemotherapy? And then you're sat there with so many people in the room looking those questions up. So having a senior person do the preparation, we thought was fundamental, as they hopefully would answer those questions independently, but just that one person. And they would produce provisional plans, which would be distributed to each member of the MDT the day before. And those provisional plans would be already entered into we use the Somerset Cancer Register, so they'd be already pre-entered, allowing for straightforward cases really to be very briefly presented and ratified, and time given for complex cases to be discussed. And then those outcomes are distributed on a Word document and into what we use as Cerner Millennium. So I'll just take you through that. So next slide, please. So this is our MDT list. It's on Teams. There's a drop-down box, if you see, on sections. Those are the sections that you can, are the headings as patients go in. Sorry, there's a chat, but I'll ignore it. And then you put in the reason you've added the patient, and then the results and plan would be populated by the consultant surgeon. So next slide, please. So this is an example of the start of one of our MDT lists. So this is now all the post-op patients are all in order, and they're front-loaded. So the more complicated patients that require oncology input are at the start, and then benign cases towards the end. I don't know if people can see that, but that's an example. I can't really see it. Put my glasses on. So the patient at the top is, I can't remember, 65. She's had a wide local excision from our screening service. Initially at diagnosis of 20mm grade 2. The post-op histology is given, and then a plan which for this patient would be for oncotype, radiotherapy to the breast, endocrine and a bisphosphonate. And that would all be, that's your pre-plan, and that would be discussed at the MDT. And if everyone was happy, then already having been entered, we'd save that. And if there was any change in that decision, then there's an ability to change, but usually they run quite straightforwardly and as quickly as that. And I think this is really achievable mainly because when you talked about individual organizations, we have a really good and reliable pathology department. So we know when our pathology will be back on a certain time frame. Sometimes they're not back by a day or so, but in general, we know that our pathology will be back for specific meetings. And also we have a really good IT setup, so access to information both for results and history are really quickly accessible with our IT departments. Next slide, please. So this is Cerner Millennium. This is how we get our documentation, and this is what's populated onto the patient record after they've been discussed at MDT. So the reason added is at the top, the plan at the bottom is under plan. There are some arrows if you press the buttons, but anyway, so that would be how that information would be delivered into the patient record, and they come in the next day. Next slide, please. So just going to take the opportunity to say how we're going to move forward with this. So in the maybe 5 years ago, plans for post-operative patients were quite straightforward, and they've become more and more complicated. So we have new treatments, abemaciclib, olaparib. We've got de-escalation of treatments with partial radiotherapy. So things that patients we thought were quite simple and straightforward have become less so. And the most complicated pathway we have is eligibility criteria for genetic testing and a PARP inhibitor, which is the R44 criteria. So actually we now have, there's an increased time required to prepare the MDT, and actually there's a possibility for omissions and errors in that pre-population. And I'd say within an MDT. Next slide, please. So we've moved forward to try and develop and implement a functional algorithmic database. So many of these decisions that we make are although they may seem complicated, they're all based on very similar criteria of parameters that we put in. So age, TNM staging, ER positivity. So many outcomes, but similar parameters. And we wanted to combine the functional aspect of something called predict. For those not breast surgeons, we use predict to discuss whether patients will be good to have chemotherapy, but also to have a database to be able to accurately gain information in the future for all our patients. Next slide, please. So this is an example of the parameters that we use for decision making for patients with breast cancer. So type and grade, ER status. Next slide. We also send our patients digital questionnaires. These are sent to all of our patients that come through the breast unit, and it gives them opportunities to put down their family history and ages of any patients who've had breast or ovarian cancer, which aids our R208 criteria. Next slide, please. And these are examples of algorithms. So, for example, if you're going to have a partial radiotherapy, you've got to have had breast-conserving surgery, you have to be over 50, you have to have had invasive ductal carcinoma. This is the first line on the left-hand side. Node negative, etc., etc. And then across the top, there are a number of eligible outcomes. Next slide, please. This is the really complicated eligibility criteria for the R44 or PARP inhibitor testing. For anyone that's involved in breast, they'll know that it's really complicated. It involves staging pre and post chemotherapy. It's but complicated. Next slide, please. So this is the algorithm that the computer science students at Bristol University are developing with us. This would be the homepage. Next slide, please. You'd enter pre-populated, so that's information about their age, date of birth, name, MRN number. Next slide, please. That will be your pre-op diagnostic information. Next slide, please. And then you'd press, so this is family history, giving us a Manchester score. Next slide, please. You press analyze, and it will give you eligibility criteria. This is at the pre-op stage. So this patient, because they're node positive, HER2 positive, could have neoadjuvant first go. They're a T3 tumor. So therefore qualify for pre-op staging, and because of their family history, would qualify for genetic testing. Next slide, please. So then the post-op information would go in. Next slide, please. And then an analyzing would give you your eligibility criteria. And it's not prescriptive. It just tells you that they're eligible for those treatments. Next slide, please. They're at the stage of just finishing off some minor issues, and then we're going to pilot this through MDT, which is our local hospital in Bristol and here in Bath. And then we're going to roll out through the Southwest and then potentially a national rollout. That's me done. Gone too fast now. 10 minutes seem not very long.
Brilliant. No, we're well ahead of time. I think I had 15 minutes allocated to my introduction.
Yeah,
I just don't need 15 minutes. So no, that's great. I think it just builds in a bit of extra time for us as well. So anybody got any questions? I mean, brilliant presentation, so much detail. Thank you. Ellen.
Hi, thank you. That was really interesting. I just have a question about your like triage resource. So is that surgeon or oncologist that does the triage job planned? And if so, or if not, and then what's the backup for if they're on leave, if it's just one individual?
Triage mean the people who do the provisional plans?
Yeah, sorry.
Yes. So we have 5 hours. There are 4 of us, and when we're on leave, we swap. So it's job. It has to be job planned.
Yeah.
It takes away, so much time from everybody else. So if it's done properly and job planned properly, yeah.
Thank you.
Thanks, Nikki. Thanks, Ellen. Robin.
Thanks, Nikki. That was really fantastic, really interesting. Just wanted to know about your use of Teams to collaborate on building MDT lists, because I've never seen that used before for that purpose. I just wondered how that came about and the process to implement that.
So we had a junior manager who's entirely easy with IT, and it's just a simple Excel spreadsheet. It's because it's on Teams. It's through the NHS mail. It's in terms of IG, it's safe. They're removed every week. He just developed it, and it's really good because when somebody else is populating a screen, you can see who's on it, so they don't overcopy anybody else's. And it's just it runs. It's brilliant. We had a different system which was nowhere near as good, but this it just works really well. You can access it anywhere through Teams.
Yeah, and is that accessed just by people in your trust or from other trusts?
So it's no, you have to have specific.
Yeah.
So it's as people come in and go out, then they get access and then not access. So I expect if you're outside the trust, you could be given access, but we don't. It's just in-house.
Okay, great, thank you.
Thanks, Robin. Nikki, Olamide.
Hi, Nikki. That was really
Hi.
good and enlightening. Yeah, just wanted to ask you, in terms of your meetings, your MDT, are they purely virtual, or do you have components of face-to-face?
So we're mostly all face-to-face. A few people still are virtual. I just don't feel it's as good, the conversation, if you're virtual. That's my personal opinion. I wish everyone was back in the room. But we have it's hybrid, but mostly face-to-face.
Thank you. I've got a question from Nikki in the chat, and I think probably we saw it on the screen. Assuming the Teams information is linked back to SharePoint.
Oh, what SharePoint?
It looked like that was where the document was stored on SharePoint. So I'm going to make a call and say yes, because I saw it on the browser link. So Kathy, yeah, I think it was. I think the way it's set up, Teams and SharePoint are kind of inextricably linked now in terms of the connecting those two storage places for documentation. So just to respond to that question,
and they're all deleted. They're all deleted on a weekly basis.
And yeah, Tam's in as part of that. It's a quick one for me, Nikki, if you don't mind. In terms of what was the before picture like? Because obviously you've done some improvement work here. You've introduced this.
Yeah.
What was? Just describe to us what you felt was the driver for this change.
I just got irritated by lots of people falling asleep, saying to the oncologist, do you want to give radiotherapy to this person who's had breast conserving surgery? I mean, so much of it is very, very algorithmic, it's the same old, and I just wanted to spend time with the people, with the complex conversations. I just hate time wasting, repetitive things that we're saying again and again, and not enough time to discuss complicated cases. We went from paper with someone just reading stuff out, and just going to that very first streamlining talk that must have been a long time ago, just seemed very obvious that we needed to do something. But then this very much resistance to doing a separate MDT, and the whole. By the time you've gone through deciding who's going to go into that MDT, you might as well have done a plan, and it all happens very swiftly. So I know we're slightly against the grain, but it works well for us.
Yeah, correct. Yeah, sometimes you just be a bit of the rebel. Yeah, good stuff. Mohammed.
Thank you, Nikki, for the excellent presentation. Just a quick question. So I understand you do the MDT preparation on Microsoft Teams, and then the actual MDT outcome is on Somerset.
Correct.
How does the two system communicate? Do you have to does it duplicate your work, or?
Yeah, so we have a really good MDT coordinator who cuts and pastes from one to the other. We have been introduced to a system called Blue Prism, which I think there's going to be an acceleration in all this AI that's going to do everything for us, which can pre-populate histology, and that I think will be an IT change that has to be at a higher level, depending on how the world changes. This algorithm that we're producing, we're trying to persuade Somerset to put it into as a function, but obviously it's going to be challenging, the loads of implications, legal, IG, and everything else. But I think that acceleration in the digital capacity for everything that we do, hopefully will be. I think that's what NHS England digital will hopefully help us with. But yes, she cuts and pastes, I think.
Thank you.
Brilliant. Thank you. So if there's no other questions. No, great. Thank you, Nikki. Really appreciate that. Lots of learning from.
Sorry, Nick. There's
Yeah,
a
sorry.
question from Tamsin in the chat.
Tamsin, you have popped your hand up.
Hopefully you can hear me okay, but yeah, it's in the chat. So I was just wondering if using the kind of shared document had improved kind of both capture of MDT outcomes that are then put into Somerset, and also what your kind of performance status in recording is like, and your staging data completeness is
So
like.
we put all staging goes in the pre-plans, so they all go in. So I think our staging is really good. We're still a bit rubbish on performance status, and that's just getting surgeons to put in that data. But it should be better. We have a big column for performance status, which is often not getting anyone to change things is just difficult. And I think performance status for surgeons is different from oncologists, because I think it was all based on oncology data, so that they're not used to it, and mostly our patients are performance status 0. So it's just remembering. So it's not really the IT. The IT would improve things because we're good with T&M staging, but getting that information from surgeons is difficult sometimes.
Brilliant. Thank you for that. Thank you, Tamsin, for the question. So yeah, we'll move on. So thank you. Yeah, great. Thanks, Nikki, and thanks everybody for interacting with that talk. I'm going to invite Elizabeth from Cornwall up onto the platform now. So I'm going to hand over to Elizabeth, and over to you.
Thank you very much. Thank you for inviting me. I'm Elizabeth Bright. I'm a consultant urologist at Royal Cornwall Hospital. I'm currently the specialty lead for urology, but that only started 6 months ago. Prior to that, I'd been the cancer lead for urology for the preceding 4 years. And during that time, we'd made a huge amount of changes to the way our MDT worked. And I'm going to discuss some of those with you today. So next slide, please. Just some background. So the cancer MDT was actually started in 1995. It was to standardise cancer care, and every patient was discussed. But obviously, this became an increasing workload. It became unmanageable, and that resulted in translational discussions rather than patient-centred discussions. So in 2017, the Cancer Transformation Board and the Department of Health actually implemented a report into how MDT practice could change. And at the same time, Cancer Research UK was doing the same thing from a patient perspective. So moving on to the next slide. The following year, we had our first GIRF urology report, and that showed that consultant urologists were spending 2 to 4 hours a week of their DCC on MDT working. And in urology, we knew that was going to become an exponentially increasing problem, because we deal with a lot of cancers. We have a high proportion of cancer work compared to benign work. A lot of those cancers are in elderly patients. We have an increasingly elderly population. And we also deal with 6 different anatomical cancer sites in urology, whereas a lot of subspecialties will only deal with 1 anatomical cancer site. But despite all of this noise, there was no evident shift in practice. Everyone was still carrying on with their MDTs the way they were. So if we move to the next slide, we will see that then led on to 2020, where NHS England and NHS Improvement actually produced a Streamlining MDT document. And they gave us carte blanche, essentially. For the first time, they gave us a criteria of patients that could be removed from the MDT. So I've listed them there. I won't read through them. You can get the document online very easily. If we move to the next slide, that then made the British Association of Urological Surgeons respond in 2021 to undertaking a poll at their section of oncology meeting. So BAUS has different sections, and the section of oncology is urologists that are specifically interested in uro-oncology. So they polled their members to say, what things do you think could be a standard of care? Essentially, what things, what patients, what pathologies could not be discussed at the MDT, and that would still be safe. And that was then published as a document in Journal of Clinical Urology for all urologists to see in 2023. If you flip to the next slide, that will show you essentially 3 criteria that they gave us for prostate cancer, bladder cancer, and renal cancer, which are essentially our 3 biggest cancer sites. And if you move to the next slide, we've looked at those and we have used those in implementing some changes. So what did we do in Cornwall? Well, actually, I say me, did 13 changes to the MDT. And a lot of those were admin process changes, personnel changes. I removed people from the MDT that didn't need to be there. It was a change in the distribution of workload. We also implemented some effective follow-up clinics very quickly after the MDT to ensure that things could happen quickly that then didn't need to happen before the MDT. And actually, only one of those 13 changes was agreeing and implementing actual standards of care. Now, I haven't in this presentation talked about all the other changes we did because I'm aware that session 1 is more about streamlining the MDT, and for me that looked at standard of care. So these changes were essentially designed by myself and in coordination with our MDT coordinator. We have a fantastic, very engaged MDT coordinator, and I can't stress how important that is. But ultimately, this had to be agreed by the whole MDT team. Everybody had to be comfortable with the changes we were making. And to do that, we essentially took everybody off site for a morning or an afternoon to attend what was called Neurology Cancer Away Day. It meant everybody's clinical activities were cancelled, and we justified it by saying our working is going to be more efficient in the future. And we sat there and we thrashed out what we were going to do. And we implemented our standards of care changes. We came up with our protocols, which might not be as radical as BAUS or NHS England said we were allowed to do, but fundamentally it had to be agreeable to every single person in the MDT, be that a urologist, oncologist, radiologist, pathologist, CNS, MDT coordinator. It had to fundamentally work and be comfortable for everyone. If we can flick to the next slide. So what did we do essentially for our standards of care? Well, firstly, we removed benign pathology. It was amazing how much benign pathology was working its way through to the cancer MDT. We removed surveillance scans post-treatment, where there was no concerns on those surveillance scans. That's part of the consultant admin. That's not part of the MDT discussion. We removed low-risk bladder cancers. They have a predetermined set pathway that is never going to change. We removed recurrent bladder cancers where the histology won't change the current treatment or follow-up. So a great example of that is we deal with a lot of patients in their 80s with bladder cancer. It grows back. We do TURBTs to ensure they don't run into problems with bleeding. And we don't fundamentally care what the histology shows because it's not an oncological operation. It's essentially a palliative operation. So don't keep bringing those patients back because we're not going to change what we're going to do. We removed incidental small renal masses that hadn't been seen by a urologist. We have a huge number of patients that were being referred to us via lung cancer screening pathways, colorectal screening pathways, with incidental pickups of renal masses. And they were then being added by those respective teams to our MDT. They'd never been seen by anybody who sat on the MDT panel. We had no clue what those patients were like, what they wanted. So we said, no, we have to see them first. And patients who are on active surveillance with small renal masses, where we essentially just monitor them with repeat CT scans over years and years. We didn't want them being brought back every time they'd had a CT scan every 6 or 12 months. We agreed that they would have an agreed treatment pathway from the start, and it would deviate to X and Y at that agreed pathway and only brought back if there was a deviation or a change in patient wishes. So we move to the next slide. We removed low-risk prostate cancer in men over 70. So if they fitted those particular criteria, which in urologists will understand, then we didn't put them onto the MDT. They automatically went on to active surveillance after a discussion with one of our CNS team. We don't discuss patients who are on hormones for prostate cancer, where hormones are our ceiling of care. So essentially, they tend to be older, frailer patients, and if the oncologists aren't going to give them any more treatment, anything other than hormones, there's no point in us discussing them. We don't discuss patients on watchful waiting, which again is surveillance of prostate cancer rather than treatment. And there was very much a vogue for discussing every single prostate biopsy, whether that was benign or malignant. And so LATP is essentially a prostate biopsy. And so if there was no cancer on a prostate biopsy, we audited our results and we've set up a protocolized pathway for whether those patients would go on to have either be discharged, just PSA monitoring, have another fusion LATP, or have a GATP, which are different types of prostate biopsies. That does not need to come through the MDT. We've already proven which pathway they need to go down. And for us, anybody who'd had a prostatectomy, cystectomy, partial nephrectomy, or penile cancers, they're already discussed at a super-regional MDT. So it was slightly pointless and duplication of them being discussed at the local MDT. So we've moved to the next slide. Benefits for our team have obviously been a reduced length of MDT. So we were up to 60 patients, and we've gone down to 25 to 35 usually. At the worst, it'll be 40. But ultimately, we've got much better engagement from our NDT attendees. Reduced fatigue, everybody's much happier. And that's improved our quality of discussion for each patient. We have gone from those translational next patient discussions to more in-depth discussions for each patient. But I think what has been the most important change for me is how much happier my team have been, and in particular, how much happier my MDT coordinator and my cancer nurse specialist team are, because we've given them more autonomy in their roles. And by giving them more autonomy, giving them more trust, they actually find their role more enjoyable, and they therefore put more into their role and give back more to our MDT and ultimately more to our patients. Thank you.
Brilliant. Thank you, Elizabeth. Really interesting and really fantastically well described. Opening up for questions. Anybody got any thoughts, observations? William? You okay,
yeah, I'm sorry,
William?
I'm just can you hear me now?
Yeah.
Yeah.
I very much enjoyed that. Thank you very much. Quick question. A lot of what you described involved removing patients from your MDT, which I thoroughly approve of. But did you have any problems with resistance from, for example, some of your CNSs? Because there's definitely a tendency within, I'm colorectal with my MDT, that they do seem to want to discuss everyone. And I frequently find myself saying, well, no, we don't need to discuss this group of patients. And I mean, it sounds like you have the backup from BAUS in order to enforce this point, but did you have any problems like that?
No, I would say our CNSs were the least likely to be resistant. Resistance came from older colleagues who weren't cancer subspecialists, who I subsequently removed from the MDT. You have to be ruthless, you know. We had every single consultant urologist in the department in the MDT, and some of those don't do any cancer work, yet they like to come and give their idea of what should be given. Some of those were working on practices from 10 years ago, and they were either disruptive or they were ineffective in the MDT. And so our changes actually started, I haven't gone into huge detail because I think some of what we've done fits more into the upcoming sessions. But I mean, we've even changed who sees what patients. You know, we've removed patients from certain consultants' clinics. So it started right at the front end. So we've sort of gone down to what we call the cancer 5. There's 5 urologists that are sort of the cancer urologists now. And if you find that, you know, they see the right person at the start. And remember, a lot of ours are probably like your colorectal pathways in where it's a virtual pathway as well. Some of our patients don't see us until after the MDT. That's the first time they meet us. Before that point, they've seen a CNS or they've had a scan. So actually, I think if you start the pathway right at the beginning correctly, then you've got all the right people on board for it to all run smoothly in the way it should run, and it should run efficiently. And nobody you're removing is a dangerous patient. You know, you're removing somebody in terms of low risk renal cancer, low risk bladder cancer, low risk prostate cancer. These patients are far likely to die of a non-cancer cause than their cancer, even if they've got 20 more years to live. So you spending time discussing them when their disease isn't bad, you know, their pathway is never going to change. It seems ludicrous to me. The time needs to be discussed on the more complex patients. And I think our CNSs have always been on board with this because they've felt empowered, they've been educated, we've educated them, we've made sure we've done teaching sessions with them about cancers, and they keep up to date with their learning. I think if they are trying to put everybody into the MDT, it's because they're not confident in their ability to decide medically what that patient needs, if you see what I mean. And maybe some education and some input from and some learning sessions to them might encourage them. I don't know.
Yeah, it's not just confidence. In some situations, there's a refusal to accept responsibility. I find. But anyway, thank you so much. That's very interesting.
Thank you, William. Thank you, Elizabeth. Olamide?
Hi, Elizabeth. Thanks. Some of the things you discussed resonated very well with us. I'm from Wolverhampton, Young, and I've got a very good MDT coordinator who tries to get on top of things. And my question is, because after the your MDT, you talked about trying to get patients appointments quite quickly. I'm torn between who organizes that. Do you have secretaries attending? Would it be the job of the MDT coordinator or the CNSs to book appointments? And what's that process?
It's a sort of everybody really. So what we used to have was we used to have MDT slots within everyone's clinics, and if you were lucky, they hadn't been pinched by cancer services, converted to a 2-week wait slot, etc., etc. And I was finding patients that were getting an MDT slot 4 weeks, 5 weeks after the MDT. They should have started chemotherapy and moved on and at that point. And I just thought, this is absolutely horrendous. So what we've implemented is our MDT is on a Thursday afternoon. We've implemented what we call a consultant MDT clinic on a Tuesday morning. It runs every week, regardless of whether anybody's on leave. There's a certain pool of people that have to provide that clinic. And we also have 2 CNS MDT clinics on the Tuesday. One's face-to-face, one's telephone. And the reason we did that was because you couldn't bring them in on the Friday because you needed time to be able to get hold of them and tell them to come up at what time. Saturday, Sunday doesn't work. Monday, there's always a bank holiday at some point in the year. So Tuesday we thought was the safest time for that always to happen. So actually our patients are then seen, and as the MDT is going on, we have, somebody's writing down, this person needs to go on this clinic on a piece of paper, this person needs to go on this clinic. Those pieces of paper then immediately taken to the secretaries after the MDT, and the secretaries start ringing the patients and booking them in. And it works really well. And our patients love it, because I sit in MDT, what we call MDT clinics now. They should be post-MDT clinics, with patients saying, wow, everything's just gone so fast, thank you. And ultimately, that's what patients want. If they've been sent as a 2-week wait with a suspected cancer, they want their pathway to happen fast. They want to know quickly whether they've got cancer or not.
No, thanks. That's really helpful.
Thanks, great question. Thanks Elizabeth. And just a comment in the chat from Caroline just about her reflections, not necessarily a question, but reflections on from the lung MDT at Sheffield. You can just pick that up later on. Matt, do you want to come in?
Yeah, I just wondered, is your meeting shorter, or are you actually just using the time more effectively now? Because I know you're talking about having better quality conversations. So is it in the same length of time, but just you're able to spend the time effectively?
It varies. It varies. I mean, sometimes we can whiz through it and be done in an hour, and then everybody's delighted. Other times, yes, you're having more complex decisions, complex conversations. Like all cancers, there are some areas of urology that's completely changed. For example, we didn't used to discuss any patient that had a nephrectomy because everybody just went on to CT surveillance. With the introduction now of pembrolizumab and immunotherapy, we have to now discuss those. So patients we'd actually taken out, we have had to add back in the last sort of year or two. But yes, it's a combination. Sometimes it's better discussions and still the same length of MDT. Sometimes it's shorter MDT. Either way, everybody's happy because they don't feel like they've been sat there unnecessarily.
Yeah, brilliant. Thank you.
Yeah, really interesting point there, Matt. I think that how do we define improvement? Is it just make things shorter, or do we make it better quality? I think that's a fair challenge. Robin.
Hi, Elizabeth. You mentioned having an away day in order to agree the standards of care. I was just wondering what you did on that day that you found most effective that led to that agreement across the board.
So the very first one was let's brainstorm some ideas from everybody. We want to hear everybody's opinions on whether you love, hate the MDT and how it can change. And actually, the very first one, everybody came, even the people that subsequently were then removed from the MDT. And then we ran that 6 monthly for 18 months because we felt we needed to keep checking in. And then we got to a point where we were like, we haven't really got anything else to change at the moment. We're all happy. So then we left it for a year. And then I think now actually it's been about a year and a half and we're saying, should we have another one? What do we need to change? And, it's a refinement process that actually now we're down to minutiae. And that's probably stuff that we can then just have a 5-minute discussion about actually at the end of the MDT or an email discussion or something. But yeah, it was a sort of start with a brainstorming. What does everybody think? What's feasible? How's it going to work? And go from there.
Great. Thank you, Elizabeth. Thanks, Robin. And Dawn, do you want to come in?
Oh, thank you very much. Great presentation. I'm really, really interested in your post MDT clinic. We're in the position where we have our standard clinic on just 1 day a week, which happens to be the same day of the MDT. You can automatically see that there's a 7 days potential add to the patient's pathway. But for me, more importantly, 7 days of uncertainty for the patient that we could be avoided if we contacted them sooner. And it sounds like an easy fix, doesn't it, to do a post MDT clinic. I'm just interested, what's your ratio of how many of those patients are face-to-face appointments required or phone call appointments? Do you have that ratio?
I don't know it off the top of my head. I would estimate it's probably about 60-70% of face-to-face, 30% are phone calls. I think, again, as I was sort of alluding to with the colorectal pathway, our prostate cancers patients, vast majority of those don't actually meet us until they've had all their investigations now. It's a nurse-led pathway. It starts with a CNS telephone triage appointment, essentially, to determine, why did the patient have their PSA? Why, are they fit enough to have for us to do anything to them? And then they go on and have an MRI scan, followed by potentially a biopsy, followed by MDT discussion, followed by then us seeing them. So they have to be face-to-face at that point, because if we've got to the point where it's like, okay, well, this person actually probably needs their prostate out or they need some radiotherapy treatment. Now, we then divvy it up. So there's no point, essentially, if there's a patient who is only going to be suitable for referral through to oncology for radiotherapy, there's not really much point in me as a urologist, as a surgeon, seeing them. So we say, okay, that one needs a prostatectomy, that needs to come to the consultant MDT clinic to chat to a surgeon. And our oncologists are more than happy for our CNSs to say, okay, that one needs radiotherapy. So bring them to the CNS MDT clinic. They'll have a chat with them, make sure they are suitable for radiotherapy. They're not sort of being wheeled in on a stretcher with only 3 weeks to live type thing. Let's make sure that they're sensible. They would be able to get on the radiotherapy table and get through the treatment. And then they refer them on to the oncologist. So it is a collaborative working. You have to have that trust as well with your oncologists, your CNS team. We do feel like we are one big group. It's not a them and us between urology and oncology in our department. But yeah, there's patients, of course, where you think, what's the point in making them drive 30 miles for me just to tell them that? And some of those patients as well have already contacted our CNS team, and they know the patient very well, and they'll say, oh, it's all right. Yeah, I've told them, they just want a phone call. We're going to give them a quick chat. So you can often work it out. I agree face-to-face is better, is nicer. And I agree face-to-face MDT, absolutely. We hate virtual MDTs. This only works if it's face-to-face, really.
Well, thank you.
Great. Thank you, Dawn. Thank you, Elizabeth. Right. And just as we line Praveen up, I'm just going to say thank you very much for that talk, Elizabeth. Really interesting. I think what I took away from that is a couple of things. It's valuing that away time, that time to think and to reflect that is as important often as the doing stuff that we do, so we can get caught in the trap of the doing mindset, but actually that's stepping away. And then also sometimes it just takes, as with Nikki beforehand, it just takes somebody to drive it to start off with, get things moving. It's bringing that inspiration and that drive forward, and I think that's the challenge to everybody on the call, is about, we can look around and think who's going to do this, but sometimes it just has to be us that makes that first change. So thank you for that, Elizabeth. Really interesting talk. I'm going to bring in Praveen from Shrewsbury and Telford.
Hello,
Praveen,
thanks for holding.
over to you, sir.
Thank you. Can you hear me?
Yeah.
Yeah. Oh, thank you. And thanks for sharing the slides for me, Robin. I've been having real problems with my trust laptop. So I'm Mr. Pillai. I'm the consultant urologist at Shrewsbury, and I'm the MDT chair as well, and a clinical lecturer in surgery with Kiel. Next slide, please. In Shrewsbury, I don't know how many of you know about our geographical specialty as such. It's our catchment is really, really huge. We cover almost the whole of the Mid Wales as well, on top of the Shropshire and Telford. We were having really big problems with our MDT because of huge case volumes and very limited workforce availability. To give you a snapshot, we only have like 2 uroradiologists and 2 uropathologists, and one is actually part-time as well on that. We were having a lot of issues with the floating workforce, the locum workforce, who may not truly stick to the protocols, and we get a lot of referrals with incomplete patient details applied, and quite a few number of times unnecessarily getting reviewed in the MDT, multiple reviews of the same patient. And at one point, if I tell you, it was becoming a bit of a killing session. We started 12:30, and there has been occasions where we had to finish like 6 o'clock, closing down to 6 o'clock. That is a bit of a killer, because there is the element of human fatigue kicks in, and very much suboptimal decision makings were happening. So I thought, that is it. We need to do something about it. So Ms. Bright has already mentioned and in-depth details about the different tumor sites and such. I'm not going into much of a details on that, but I'm just humbly passing you what the key points or the key stuff I have done as my role as an MDT chair. Our West Midlands, next slide, please. Yes. So our West Midlands Cancer Alliance standard of care document has been quite helpful. I'm happy to share it if any of you want it. I think it is also available in the West Midlands Cancer Alliance website. So it gives you a really good heads up into how to streamline these sort of busy MDTs. And the key thing that has actually added the nitro fuel to our MDT is a good case preparation. All of us have been given some time in our in our admin to prepare for the MDT, and believe it, it just changes the pace of the discussion. So the less sort of every case is important. Every document is a patient's life for us. But what I'm trying to tell is we will be able to give more sort of valuable time effectively for the cases that it warrants, if you do prepare your cases properly, and avoiding unnecessary sort of repeated case discussion. So we actually split our lists into 3 different lists. The one is a main list where we discuss all the tumor sites, and I have highlighted that notification list. That is where all the protocolizing stuff will go. And once we actually started using the notification list, immediately about 10-15 plus cases just disappeared. So we these sort of low, as Ms. Bright was mentioning, the low risk tumor, the bladder tumors and things, the consultant will update on it, and the MDT coordinators will do the updation on the Somerset Cancer Registry, and we close the flag wherever it is appropriate to do so. And we don't. It took off a lot of workload, especially from our radiology and pathology colleagues. They don't need to just go back and recheck these sort of things again. And obviously, we have the SMDT list. The protocolizing the cases and the guidance from the West Midlands Cancer Alliance has been quite useful for that. All these we haven't yet done the small renal mass protocolizing as such because of some network working issues there, but it did remove a lot of unnecessary case discussions or spending a lot of time in discussing those cases. And the other key thing is a regular communication between the MDT coordinators and the MDT lead. That is one of the keystone in making the changes, I would say, and strict gatekeeping. To a level, it takes a lot of my admin time, I have to say, but at the end of the day, I'm happy that I don't pass my sort of hands any of the cases that doesn't need to be discussed. And obviously I do feedback the members who are not adhering to the protocols. I keep it a bit soft, I have to say. So next slide, please. So these are the general rules I brought in, and I just stand for. Simple things. I was not inventing any new wheels. I've been just searching all the good behaviors that should be there, and then making it stand up for it. So unless the investigation is reported, it is not for MDT. You may ask, yeah, will it not delay the case discussions? Yes, it can, but you have to be quite vigilant about that. Especially, I'm sure it may be across the country. We are using the sort of outsourcing reporting for our CTs and things. So the important cases where we cannot wait till that time when these will be when these report will be available, we do have a very strong support from our uroradiologists. The moment you email them, the report is ready. So that is where the communication between the MDT chair and the MDT coordinators and the uroradiologists, it comes into play there to fasten up the discussion from that perspective. Incomplete staging, not for MDT. We are using the CNSs have been very supportive on that, and there will be communication between the MDT coordinators and the CNSs, and also with me, where there is an incomplete staging. It won't come to the MDT wherever possible without those scans being performed and prioritized reporting by the radiologist. And this is another point, is if the scan report is unclear, the uroradiologists have been very supportive. They do have their dedicated time for their MDT. If we don't eat into that time, they were happy. So any time outside that that MDT reporting time dedicated for them, they are happy to support it. You send an email within 24 48 hours. We get the report. I mean the response back from them. So that prevented a lot of cases being brought to the MDT, and I do get regular emails about the cases that has been referred by other teams to urology MDT, and example is a CT scan showing some bladder wall thickening. What am I going to do with that? What I will do is I will do a letter to the patient. I will book a flexi, And then you know, the MDT coordinators will keep tracking on it, possibly open a flag as well. And then we don't bring the patient for MDT. So these sort of small interventions, it makes a huge change. And benign cases, definitely not for MDT. It will be pinged right back to the referrer. And sometimes, you know, we get these sort of referral for unclear sort of report in the CTs and things. So what I do is I just send it off to our uroradiologist, email them, and copying the referrer. And then when we get the report back from them, I decide whether to take it for MDT or not. Otherwise, the referrer can discharge because they have got the case cleared by the uroradiologist. The people do have, or the consultants do have, the habit of putting a line under the operating note. Oh, after doing TURBT, MDT review of histology. Don't need to, because, you know, what is a low-grade tumor? You're going to bring it to the MDT to review. And that all will go into the notification list. And one other thing is, which we are finding it quite difficult as well, is a standardized reporting, because it's not it is outsourced. So we encourage to have some standardized reporting and quite a strict adherence to the closing timeline. The vetting will be quite strict after the closing timeline. And in short, you know, it's very strong message there is MDT is not an admin platform. Next slide. And thank you.
Thank you, Praveen. Really, really interesting, and some great points you made there. And I love those general rules that you establish for how you work. You know, just being really clear about what is and what isn't around. I'm going to go over to Mark. Got a question for you. Mark, you might be on mute if you're trying to talk.
Sorry, just taking. Can you hear me now?
Yeah.
Oh, yeah.
Thanks, Praveen. That was really nice talk, and obviously things needed to change given the number of patients that you had when you took over that process. I think, I mean, I'm part of an HPB, hepatobiliary MDT, and we struggle with some of the things that you've excluded because of the trying to differentiate between benign and malignant disease. You know, is very difficult with HPB disease.
Yeah.
So having a fixed rule where things are definitely benign is actually quite difficult, and the scan may have been reported elsewhere as benign, but there's still some suspicion that there might be something going on. And I think this is a definite difference in the disease pathologies, in that we can have cancers that are very definitely suspicious based on other factors apart from a definite tumor seen perhaps within the pancreas. You know, you can have pancreatic cancers with no visible mass. So it gets very difficult to have an algorithm that removes patients definitively from the MDT by doing an MDT vetting process the week before. So, you know, just going through it, I'm just looking at your comments. So, you know, the other problem we have sometimes, it says one of your first points was that if the investigation is not reported, then not for MDT. Now, in principle, I agree with that, but we've had difficulty with that in that the timing of the closure deadline for our MDT may well be before the radiologist is going to report that scan. So I don't necessarily know that scan's not going to be reported by the time the MDT comes around. So we have to finalize our MDT on a Friday for the following Tuesday, but that scan is probably going to be reported by then. So that becomes difficult because you then add in another week to the patient pathway. And as we all know, the push to reduce timed pathways is huge at the moment. So adding in another week of lack of MDT review, can be problematic for that. So it's trying to find a way around that without adding time to patient's pathway. The vetting is quite troublesome. I've found. I've tried to do this for our MDT, and with the best will in the world, it's difficult to get agreement from all consultant colleagues. I can spend a considerable amount of time back and forth about why I don't think this patient needs discussing, and my consultant colleagues say, no, I still want to discuss it. I still want to discuss it. There's still a reason for discussing it, and it can just be a huge waste of time. Whereas if it was on the MDT, it might take 10 minutes to discuss the case, whereas it can take half an hour back and forth, trying to remove the patients from the MDT. So I think that can be tricky depending on the makeup of the MDT characters that you're dealing with. And I completely agree with histology, although we have a significant number of false negative FNAs. So having a negative histology in our patient cohort definitely does not mean that patient doesn't need to be looked at again, because it's often the suspicion is high and you may need another biopsy. I welcome your rules. It looks as though it's worked really well for you, for which I'm delighted. I struggle with introducing those into our MDT scenario, but would welcome the further presentations to see how we can push things forward a bit and at least try and make some inroads into our burden of MDT patients. So I haven't got a question.
No, that's good, Mark. It's a fair challenge, and I'm sure Praveen didn't have an easy life to start off with.
No. It's a good point, Ms. Peterson, because the first thing is that it's very interesting to attend these sort of meetings, and so that we get a heads up regarding what is happening in the other specialties as well, you say, because MDT has never been like a blanket approach, isn't it, at the end of the day, because tumor behaviors are different, the way the case presentations are different. In urology, first, about the benign case thing, we do get a lot of benign stuff that gets unnecessarily escalated. One example is the one great example, maybe the renal cyst, you say. So the lot of CTs, especially the outsourced CTs, they leave it very gray regarding a renal cyst, which can be easily clarified by sending an email to our uroradiologist, and they say simple cyst, that's it, done. So that kind of thing. So it may be a little bit difficult on your side. I have to agree on that, because your cyst may be different from our simple cyst. And secondly, about the investigation getting reported, this is more important for a case that is getting discussed for the first time. And for example, if we strictly stick to the protocol, the guidelines, if you happen to see a muscle invasive looking bladder tumor, it doesn't stop you from requesting straightforward a CT chart, like staging CT scan from the Flexi clinic. And by the time the things are getting ready, that report will also be ready. And that is where the communication, if that CT is not reported at the time the histology is done, we just send an email, and the radiologist will make sure that the report is ready for the MDT discussion. That kind of approach. And certain tumors, we have given some exception, especially the bladder tumors, which are and the upper tract ECCs, which are quite an aggressive kind of which shows aggressive tumor behavior. So those sort of things, it does get tracked properly, and also those reportings are done on a priority basis anyway. I hope that answers your query. Is that?
Yeah, absolutely. I think it's as we all know, it's different for different tumor sites as to how much you can protocol things, and I think that's some of the difficulty that we have.
Yes,
Yeah.
I agree.
Thank you both. Really, really great discussion. I hope other people have found that helpful as well. I'm going to go to Ellen and then Alamidi, and then we'll go back to Ellen for her presentation.
Thank you. So reassuring, I think, to hear that you've found issues around patients that really shouldn't be going to MDTs. I just wondered if you needed to kind of seek permission to remove those patients, or whether you had any pushback. I think what we've seen in North East London is sometimes we use the MDTs because we don't trust the kind of processes as a safety net, essentially, because there aren't necessarily the processes in place to track or monitor those patients outside of the MDT, and we use the MDT for that. How did you give reassurance to the MDT that those patients would be safe and safety netted if not brought to the meeting?
That's a good question, Ellen. The thing is, we don't, I think using the, the pushback and rejection, that is not the approach I do. Even if it is any other team, is that's mostly these sort of scenario is when you get the case referral from another team, and if they are asking for a clarification regarding, say, for example, a complex cyst in the liver, or sorry, the liver. It's Mr. Peterson's influence. A complex cyst in the kidney, or a bladder wall thickening. We are actually trying to address it by involving the relevant team, for example, the uroradiologist, to give a comment on the cyst, and they are feeding back to them saying that this is benign, no need to discuss it formally, that kind of thing. So it is not like a pure rejection as such. And if I make if I have not been very clear about that, my apologies.
Thank you.
Brilliant, thank you. Quickly to Alamidi.
Hi, thanks for the talk. My question is, do you have strict pro formas for referrals to your MDT? And, in terms of tick boxes, these investigations have to be requested before they come in. Otherwise, they get rejected. Now, for those that have made it onto your MDT from another specialty, if they need some test doing, do you then go back to those specialties and say, can you kindly request a CT scan? Or do you take on that role of just doing the test yourself? Which means if you take on that role, you're giving yourself more work. But if you go back to the previous specialty, then you're delaying things.
It's a really good question, and quite a relevant one as well. So we do have the referral forms, which is quite clear, and this is from our West Midlands Cancer Alliance as well. That is, those forms are approved by them. So usually we do get the relevant scans at hand, but if I don't have the scan, depending on the tumor, say for example, if it is for a suspected upper tract TCC and things like that, which is quite aggressive, I take it to I don't push it back to those teams. We make sure that those scans we do request it, because otherwise it will unnecessarily lengthen the management pathways.
Thanks.
Thank you both. Yeah, brilliant. Thank you for that. Really great discussion, and it's really great to build in those questions. Thank you for stimulating that discussion, Praveen. Really, really helpful. I think Robin's put something in there in the chat just to pick up on that around maybe some future session about how we can empower people, and really building some of those decision makers. Thank you so much for that. Really helpful. Ellen, over to you. I think you're going to share your. I think. Robin's going to drop these slides down and you're going to take them on. So over to you.
I am, yes. Let me just go into it. Perfect. It's not going into slideshow mode, but there it is. Thank you for having me. Really interesting to hear about some of the other talks. I think there are going to be similarities. I think we're all trying to do similar things. But I think the difference perhaps in approach that we've taken in North East London is that we're trying to do it in a lot wider scale. So we're trying to do multiple tumour groups, all our MDTs within those tumour groups. In London, we have trusts that same trusts that work over kind of 5 different hospital sites, so some challenges within that. Similarly, to Elizabeth, we are doing this as part of a wider MDT improvement programme that we started about 18 months ago. We've got some other work streams within that around training and education and technology, which I won't talk about today, but very happy to pick up offline with anybody that would be interested. But today we'll focus on streamlining and standards of care. So, you know, as we know, the streamlining, or the call to streamlining, came from the NHSE guidance that came out in 2020. Our objectives for this project were about evaluating the implementation and the impact of streamlining, supporting our MDTs to implement the streamlining process, and then developing ongoing resource to support those that to continue to embed it into practice and to kind of have that audit and in the absence of peer review, and to as a resource after the programme's closed for MDTs that might want to implement it subsequently. Worth noting that we're very lucky to have Tana Sukat working with us, who's an implementation scientist at Imperial College. We've really consciously taken the approach to have a evidence-based, sustainable approach to streamlining. So it's not been the quick, immediate win that the trust perhaps wanted from us, but a very kind of slow, considered approach, so that it has the chance of being more sustainable. So we had an engagement strategy for streamlining. So we cast the net quite wide initially, had lots of webinars with anyone and everyone was welcome, talked to our providers about their priority tumour groups and what their challenges were, went to all of our ERGs that the Alliance kind of host, and sort of introduced the concept to get understanding of who would be interested and where it might work for them. Based on those things, we and because that we have a finite resource within our group of 3 of us, we initially working currently with breast, urology, lower GI and gynae, but all those MDTs across our 3 trusts within North East London. So that's not 4 meetings, that's 4 tumour sites. Would strongly recommend anybody to map those MDTs. So this is our MDT structure within those tumour groups. As you can see, none of them are quite the same. Still kind of getting my head around it. We have local MDTs, specialist MDTs. As I say, we have a trust that has 5 hospital sites within it. Some of those each have MDTs. Some of them have 1 big meeting, but it was really helpful to kind of put that into paper to try and kind of understand it. But the approach for those meetings and for those tumour groups will all be slightly different as a result. So again, Elizabeth mentioned earlier, so there's a urology theme here today for sure. So I'm incredibly lucky to have Ben Lamb as my clinical lead for MDT improvement in North East London. And Ben was one of the authors for the Bowels Oncology guidance that drafted a framework for the standards of care for streamlining. And based on that guidance, he and Tiana further developed this SOC framework that we have used with our tumour groups to develop and establish those SOCs. Worth noting as well that as we're leading it from an alliance perspective, there's a governance framework, and where this programme sits within our governance framework as an alliance. And these SOCs have all been to ERGs, our ERG meetings, and been signed off formally at that level. So this is an example of our urology one. Again, my advice would be to make it as detailed as possible. Ben often describes it as kind of, imagine if aliens came down and wanted to start streamlining patients, and to really have it as a very detailed guide, so that it's not discretionary. It is, we have started with those simple cases, and as you can see, there's some benign cases in there that we've kind of alluded to earlier, but to really have it as detailed as possible, so that in theory anybody could come along and have a good idea of which patients needed streamlining, which would be eligible for streamlining. And worth noting that those are iterative documents, so we've encouraged our MDTs and our tumour groups to start small, start with the basics, start with the simple cases. This isn't set in stone, it can grow, it can be added to, it can be amended as we go. So these are the SOCs that we've developed for our 4 tumour groups. So these, as I said, alliance and are done at tumour group level. So these have gone across, are in place for all of our trusts at tumour site level, not at MDT and not at trust level. Currently, we've got, or as it stands, we've got 54 cases or patient groups that would be eligible for streamlining within those 4 MDTs. So just to touch a bit on our implementation approach and auditing and kind of embedding and sustaining that practice. So as we know, the guidance that came about in 2020, and really this is just to highlight how we plan to build in audit to streamlining, to give that reassurance. We have obviously had some hesitancy from some clinicians, and how we safety net and assure them of that process being safe. So auditing that the right patients have been triaged, auditing that the standard of care was followed, and what that recommendation was, that it would be the same as if that patient had discussion, and whether that SOC and the clinical management was followed. This is just a bit about our breakdown of work and our timeline in terms of engagement and implementation. We're currently in the implementation phase. Some are further on that than others, and some are a bit more engaged in that than others. We identified some early barriers that came out of those meetings that we had with the tumour groups to establish those SOCs, and there's no real surprises. So staffing issues, time constraints, variations in practice, pathology availability or report availability, but interesting to capture this so that we can see if they actually were just anticipated barriers or actual barriers. So what we've then done, I think, to avoid kind of numerous meetings with very busy secondary care people, we've sent out a questionnaire, and this was done at MDT level, so to each meeting within that structure that I showed earlier. And I think this is to make sure that we capture the current functionalities of the MDT. Obviously it's there for decision making, but there are lots of other things that happen within that meeting. So tracking patients, outcoming patients, booking onward follow-up, how they get recorded, how they get referred into. And that's really, we need all that information to make sure that that triage meeting is able to do all those things that the MDT meeting does. So what we don't want is to create a different process and things get lost, and we don't have the benefits of that MDT meeting. So really to make sure that that triage meeting serves the same purpose and performs the same roles and purposes that the full MDT meeting does currently. So then we've used those questionnaires to create a very detailed bespoke implementation pack for each of those MDTs, and this is just a kind of summary from one of those packs. This is the urology one, but there's a lot more kind of detail and information in those that we meet with the MDTs and talk through with them. So things around and processes around kind of outcome recording or live recording to improve efficiency. So this particular MDT has already transitioned into using SCR to live record, as opposed to previously they were kind of doing things with Word documents and pro formas, but to live record them. These things are, whilst this features in our technology work stream, these things impact on one another, don't they? So if we can create efficiencies for the MDT coordinator within the meeting so that they haven't retrospectively got to do a duplication of their workload and enter into a different system, we therefore might release some of their time and capacity to be able to go to that triage meeting instead. Establishing that triage people, so who, how, where, when are they going to do that meeting, who's going to be in it, when's that going to happen, and after the pilot, hopefully successful pilot, we produce an SOP in terms of how that would look going forward, so that people have got that as a reference guide. Consistent staff availability for that triage meeting. So in our pilot, we've agreed that would be one person or one surgeon, But actually that might not be what happens in the longer term. It might be that we do it as a rota basis. It might be that what happens long term is that because we in certain MDTs have blessed with having a larger amount of surgeons, we're able to move one of those surgeons out to do the triage meeting. They then don't have to attend the full MDT meeting, and we avoid the need to add in extra PAs, because that's obviously a huge challenge. We're not adding in PAs for the pilot because we acknowledge that that will take lots of time and would be a real barrier to running a pilot. But it might be something that's needed for MDTs, and again, that will differ from meeting to meeting. Report availability, so how we've engaged with our radiology and pathology colleagues to have different cut-off times for triage meetings, and then building our team engagement. Who are we going to have as our champions that take it forward and kind of lead on different things. And then just to touch on the kind of resource development. So I think it's been really important for us to reassure our colleagues that this is a safe way to do, safe practice, and that, as I say, that things aren't going to be missed in that streamlining meeting that happened currently within the full meeting. So audit and ongoing audit of that process that's been implemented to reassure people that that's a safe practice and it's still working well, and that those SOCs continue to be fit for purpose. So from a NELCA perspective, we'll continue to hold those implementation meetings. As I say, some are further along than others. We're going to grow that programme in 25-26 to include additional tumour sites, namely skin. As I say, MDTs want reassurance that this is a safe and sustainable practice, and there's an ongoing valuation of streamlining with built in to that. We'll develop a toolkit, as I say, for ongoing monitoring, but also for any that want to take up streamlining after the program's ended. Thank you very much, and happy to take any questions.
Thank you, Ellen. That was really great, and so much content in there. Really interesting. We have got a few minutes for questions if anybody's got any for Ellen. Lots of comments in the chat as well, Ellen, if you want to sort of pick some of those up as well, if you want to sort of read some of those. Really interesting perspectives. No questions for Ellen, but so that's great. So I think it's a really helpful way to wrap up the session. So thank you for that. We're going to draw the session to a close from today. Just want to say thank you for everybody who's joined today, particularly thanks to all our speakers. Thank you, Nikki, Elizabeth, Praveen, and of course Ellen at the end. Thank you everybody for participating and asking some of those questions and generating some of that discussion. I think it's really been helpful to build on some of the presentations as well, and I hope you've all been able to take something away. And I guess, you know, as we said at the start of the session, it's what you can draw out from these and start to think about how you apply some of this in your own organisations and take some of the learning. And I guess is some of the challenges that we face in applying some of this. Remember that, you know, that all the case studies that you've heard today have taken time to get to this point, and there was a point when, you know, Nikki, Elizabeth, Praveen, and Ellen were at a starting point as well. So, you know, they've been on a journey, and it's how you start that journey yourselves as well, learning from the examples that you've seen. And some of you will be well on the way on that journey already. Some of you will be a little further back towards the starting line, but remember, you know, it is all about just starting. Next session, hope to see many of you on the 14th of March. That's going to be more of a group discussion around inter-provider communications and processes. I think I picked up from the chat today that there's been some opportunities to maybe develop some additional sessions or additional content based on what we've learned today. I know Robin's been putting some comments in there as well, and that may be included in some future sessions. So I think these ideas that we can generate, and if you've got any other further suggestions about what might be helpful for the team and what might be useful for you guys as a collaborative in terms of content and future sessions, please do let the team know or drop them in the chat or whatever methods of communication. And the team are going to kill me now for for doubling their workload in terms of bringing in more content. It's really useful to get your perspectives on what might be helpful for these. There are some sessions later on in this program where there are probably a few gaps that we can build in some additional subject matter content if need be. With that, I'm going to bring us to a close with 4 minutes to spare. There you go, we've got 4 minutes back. You can go and do with that what you want. Wishing you the best Friday and pleasant weekend. We'll see you all on the 14th.
Thank you.
Thanks, Nick. Thanks all.
Thanks. All right.